This presentation is on the Gonstead approach to care of the cervical spine. Take a few minutes to read this case scenario for discussion in a few minutes. Please put the presentation on pause so you have time to read it before the discussion begins. Okay, this case presents a mixed bag of symptoms and signs in the presentation of this patient. But the first one is that he complains of tightness across the lower back and into the buttocks, and these symptoms are worse after heavy activity or exercise. That points directly to spondylolisthesis. Describes mild weakness in the right thigh and spasm of the lower back muscles. Standing for long periods of time is painful, and he also is sore and has difficulty standing up completely straight after sitting in the car for 45 minutes. So that's kind of mixed bag of presentation. Standing for long periods of time is a period of inactivity, which is how your facet syndrome would present. But standing for a long period of time with a spondylolisthesis could also lead to discomfort and pain. So answering D would need more information. That is definitely a good answer, because your x-rays can give you some more information on whether it is a spondylo or facet syndrome. But overall, this case is leaning towards the spondylolisthesis, especially since he has the pain across the lower back after heavy activity and exercise. And also, standing for long periods of time is painful. Putting pressure on that spondylolisthesis while standing can definitely cause it to flare up. Even though it's not exercise, it is while the spine is load-bearing. What motion of the spine is the greatest, excluding atlas? Take a minute to think about this one. The answer to this one is flexion and extension, but more flexion. When we exclude the atlas, you'll definitely see that the spine has much more motion in the flexion, and the combination of flexion and extension create the most motion in the spine. This chart here is a chart of intersegmental range of motion in the cervical spine. And as you can see, for atlas, of course, the amount of rotation is the greatest at that level. But surprisingly, the mid-cervical spine is pretty consistent on how much motion it allows on rotation. And lateral bending also is pretty even throughout the cervical spine, excluding C1 and C2. But you will notice that flexion extension, the combination of those motions, is greatest in the lower cervical spine. As defined here inside the red oval, the lower cervical spine definitely shows more flexion and extension motion. And that is typically where we see most of our degenerative changes in the cervical spine. It has the most motion in that area, and that's where we tend to see the most degenerative changes. Also, the upper cervical spine tends to preserve itself very well, allowing for very little degenerative changes in the cervical spine unless there was some trauma or injury or overuse that has initiated that degenerative process. I apologize for the shutter sounds there. We'll try to move past those quickly. According to the Gonstead system, and actually with any system, the biomechanics of the spine really don't change. So the cervical curve is made up of both the bodies and the disc contribute to the lordosis of the cervical curve. And when we draw our feather lines on our film, our lateral film, they should meet at a like point. All the segments should meet at a like point posterior to the cervical spine. They should be nice and even in their presentation. In the Gonstead system, when we're trying to determine which bone is a possibility of the one that is the quote bad bone or the subluxated segment, oftentimes when that bone subluxates, it goes posterior and inferior in the cervical spine. And we can see that on the x-ray by drawing our feather lines, where we see one of the feather lines converge and cross the other feather lines before they all meet at their like point, which is usually way off the film. But you could see that this vertebrae is stuck in an extension position. Okay. Usually in above that segment, the cervical spine starts to straighten out, loses its lordosis, but that's an indication that's a possible subluxated segment. Remember, in the Gonstead system, we always detect and find our subluxations on the patient, but our x-ray can really help us determine if we are accurate with our analysis and also which segment may be fixated in that extension position. The analysis of the cervical spine is just like you know it from lecture 2. We do use our instrumentation. Instrumentation in the cervical spine may not be as specific as it is in some of the other areas of the spine because there's overlapping areas that can have the edema or the temperature differential since the cervical spine is so small. But it does give us the level, and we have to go in and palpate to see which segment is actually the involved segment. So it's a little trickier to read the instrument there, but it's vitally important that we do get our instrumentation reading. When we do our static palpation, the question here, where do we palpate the pit of edema in the cervical spine? Different than when we find the pit of edema in the thoracic or lumbar spine, in the cervical spine, we typically find that edema right on the inferior tip of the spinous process. That tends where that inflammation, not inflammation, but the edema tends to be there, not paraspinally, but right on the tip of the spinous. And you could feel it. It feels just like a little pea-sized soft spot over the spinous. In mopal in the spine, as we're going to see in the next next diagram coming up, you have to be really cognizant of the different aspects of the range of motion intersegmentally in that cervical spine, as we saw in the chart earlier, because flexion extension at C2, C3, or C3, C4 is not the same as flexion extension at C5, 6, or 7, and so you have to be cognizant of that when you're doing your range of motion. Oftentimes, when I'm working in the clinic and I see students often choose C2 as the subluxated segment in the cervical spine. If you look back on that chart for range of motion and flexion extension, C1, C2, and C2, C3 have very limited extension range of motion, even C2 on C3. So you may feel like it's fixated a lot, but it isn't. It's just its natural range of motion is less than it is flexion extension, less than it would be in the lower cervical spine. So that's why when you palpate up there, you might feel it's fixated often. And it's also a very easy spinous to contact and analyze. So be cognizant of that when you're doing your mopal. C2 is going to have less motion than flexion extension. As I mentioned on the previous slide, we're going to scope our patient. We're going to do our static palpation, looking for edema, tenderness, checking the musculature. We're going to mopal our segments, as always, in our 3 planes of motion to determine not only the level of fixation, but the actual listing. And we'll analyze our lateral cervical X-ray for potential subluxations. Like I showed in the slide, a few slides prior to this, when that segment is stuck in an extension position, that potentially could be a fixated segment, but you have to find it on the patient. And if we cannot tell if the segment is moving, there's one thing that we can do to determine the movement of that segment. We can do a flexion film. We put the patient into the flexed position. We take the film and we try to determine if we can see if the segment's fixated in an extension position or if it's moving freely. What you see here is a flexion film of a very healthy looking spine, and what we're looking for is to see if our feather lines now diverge evenly. Now in our normal film they should converge at a like point, but when we do the flexion film the lines should diverge from each other in a very even manner. This lets us know that those segments appear to be fairly freely movable and not inhibited in any way. What you see here is a flexion and extension series on the same patient. The photo on the left is the flexion view, and like I said, we should see a nice even divergence of our lines on the lateral view when doing a flexion film. And if you notice down there in the lower cervical spine that one of the segments still is stuck or fixated in the extension position. It did not open up that space in the posterior aspect. It stayed fixated and stayed in the extension position. You also notice that there's a lot of degenerative changes at that segment, and again, in Gonstead, that's a potential subluxation. Again, it's always found on the patient, but our x-rays can help us confirm which segment is fixated. And you look at the film on the right when we're back into the neutral. I said extension earlier. The film on the right is a neutral film. You can see that that same segment that would not go into the flexion position on the left-hand film, flexion film, is stuck in the extension position on the right-hand neutral film. Again, an area of potential subluxation. There's also a lot of degeneration at that level, so motion at that level is going to be restricted whether there's a subluxation there or not, but we have to do our MOPAL, determine what the fixation is, and get used to what is normal for this patient. When we motion that segments down a lower cervical, they're always going to feel like they have abnormal motion because of the degenerative changes have restricted the motion there. But we have to have our instrumentation reading there to even begin to thinking of adjust that area. We have to have our motion restriction, and we have to learn what's normal for that patient and what is movable for that segment. So after we adjust them, we post-check them, and we see how much we've increased the motion. So now we're going to get an idea of what we should expect with this patient pre and post adjustment as far as motion palpation goes. But again, the instrumentation and Gonstead helps us focus in on the areas that need adjustment. Just an area of degeneration or stuck in an extension position on the x-ray is not a reason to adjust. You have to have the scope reading to back that up. Okay, one of the advantages of adjusting in the cervical chair is our ability to get a line of correction that is very specific and P to A, and we can include the I to S component of this adjustment and facilitate those facets because of the segmental contact point we make. Say it's a simple listing, where we get a chance to actually lift, make our contact on the spinous. We're allowed to lift that vertebrae up, that segment up by contacting the spinous to open those facets. And then we can drive P to A because we can get directly behind that segment posteriorly. So we can go P to A and I to S, making that correction through the disc plane line, which we see with this arching line here. We begin the adjustment P to A and I to S, as we thrust P to A, we also change the direction of that impulse to then follow the disc plane line. So it has an arcing motion. But the great advantage of the cervical chair adjustment is to lift and open those facets and then drive forward through the disc plane line. I have a patient that I used to see. He was a chiropractor. He did practice in a multi-doctor practice, but about 3 or 4 times a year he would come see me in the clinic because he wanted that Gonstead cervical chair adjustment to really free up that fixation, especially with the P to A and I to S adjustment. He would get radicular symptoms down his hand for a C6 nerve root, and he had a lot of degeneration in that level. And the Gonstead adjustment, when his partners could not get rid of the symptomatology, he knew it was time to come to the Gonstead clinic and get the Gonstead P to A and I to S adjustment to make that correction to relieve his symptomatology, get the pressure off the nerve. And so there is a difference in the adjusting and what the results can be. And that gentleman did very well. Typically, it was 1 to 2 adjustments when he would come in. I said he came in 3 or 4 times a year, but typically it was probably 2 adjustments 3 or 4 times a year to make that correction to that vertebrae to get the pressure off the nerve, which is vitally important. So there is a difference, and he would come see us and then go back to his office and get adjusted the rest of the time till the symptomatology came back, and then he'd come see me again. We had really good results with him. Now we're going to discuss neck injuries, how they occur, the mechanism of the injury, and how we do care for these patients with Gonstead care. Okay. The flexion injury is caused by forced flexion of the cervical spine, and when that happens, what it does is it focuses all the pressure on that forced flexion into the anterior parts of the spine, in particular the vertebral bodies and the intervertebral discs. When that happens, it does translate that force typically down to the C5, C6 area and tries to force that area into like a posterior translation. This leads to soft tissue injury in the posterior aspect of the spine. It could be the facets, the joint capsules, or the ligaments connecting the spinuses back there, but it leads to some of the compressive injuries in the anterior part of the cervical spine. What we see in this film, the patient has a very straight military neck with no curve. You could also see at the area of at the area of 5-6, C5, C6, there is a tremendous amount of disc degeneration and some spurring going on at those segments. But you'll notice the segments above and below it that have almost no degenerative changes going on. When you see this type of scenario on your patient, that tells me that this patient has experienced some sort of injury or trauma there in the past. And by the looks of this presentation, with the spurring on the anterior aspects, the disc showing a lot of degenerative changes, and it's really difficult to tell, but C5 looks like it may be a little bit posterior on this view. Okay, I would suspect a flexion injury in this patient. Okay, now when comparing practicing 30 or 40 years ago compared to practicing today, we really do see less of these flexion injuries. And the reason is because now we have airbags in our automobiles. Prior to airbags, the only thing to hold the patient to the seat in a front-end collision was the seat belt. But that left the head and neck freely movable to go into a forced flexion position and created a lot of those whiplash injuries, especially a forced flexion extension injury. But now, because of airbags, we see less of these, or if there is one, it's less severe because they will get caught by the airbag, especially in a flexion injury. Again, this is a classic presentation of a cervical spine that's showing degenerative changes. Again, the degenerative changes typically start to show up in the lower cervical spine first. You can see here we have disc degeneration and facet arthrosis. As the degeneration has progressed in the cervical spine here, not only have the discs gotten narrow, you see the vertebrae now get reactively larger, because what the vertebrae are trying to do now, since they lost the cushioning of the disc space, they're trying to make themselves wider and broader to now absorb more energy over a larger surface area. And it's trying to make up for the lack of cushioning in the disc. But typically we see this presentation in the lower cervical spine. And this is just normal wear and tear, perhaps a minor injury early on. And this is typically what your patients can present like with no changes in the upper cervical spine. This film is another film of the analysis of the Gonstead system for the cervical spine on the lateral film. You could see that this spine has lost its curve in the mid to upper cervical spine, actually a little bit of a reverse curve there in the middle. And when we draw our feather lines in there, you could see that the lower cervical vertebrae are stuck in an extension position. When that happens, the cervical spine above that wants to compensate. So if you take the C7 vertebrae and put it into extension position, if nothing else adapted, the patient may be looking up higher off the horizon. But the patient doesn't want to do that, so the body will then level the eyes to the horizon. When it does that, since C7 will not go into its normal position, it will then cause the mid and upper cervical spine to adapt. And this is a classic adaptation to a C7 stuck in a fixated extension position, and the rest of the cervical spine now adapting to that position. Okay, now we're going to talk about our extension injury. Although modern cars have airbags, the one place that we are not protected in as well is the extension position. We do have headrests in most cars, but they have to be set up properly, and you have to be able to fit in your car seat the right way to have those headrests protect you against the extension injury. Now, these injuries do not only occur in automobile accidents, but the automobile accidents definitely have the potential to have a much higher energy into the accident with that forced flexion extension. You can get these at a slightly less level for slip and falls, where people can slip and fall on their bottom. And when that happens, they get an extension injury because their head kind of whiplashes back. This could happen in a collision in an athletic event where somebody gets hit or pushed from behind with not expecting it, and they're not protecting. They can get this extension injury. Now, when we have the extension injury, the lower cervical spine protects itself very well by kind of locking up the facets and protects the disc because now the discs are opening instead of being compressed as they were on the flexion injury. So now that damage gets focused and translated up the spine because we have the facets locking, and that leaves the upper cervical spine prone to these injuries because you have the large, very heavy head sitting on atlas and it gets forced into extension position, and now it will focus the force in the upper cervical spine, and it'll highly affect the joint capsules of the cervical spine. Okay. Our atlas subluxation is the fixation between atlas and C2. The fixation is caused or seen on the X-ray and defined as the swelling of the joint capsule. The side of the open wedge on your A to P view is the side of the fixation, or not the fixation, but the side of laterality in the atlas subluxation. The fixation is always found on the patient. I know that on some of our lab quizzes, people were confusing your toggle listings with your Gonstead listings for upper cervical. In Gonstead, we always compare the segment above to the segment below. So we always compare atlas to axis when we're analyzing for atlas subluxation. The open wedge on that side tells us the side of laterality. Okay? And it should correspond with the fixated side in our MOPAL. I know in MOPAL class here, they teach you that rotation is the primary way to determine the fixation at atlas, but going through school and still today, I use my lateral flexion analysis of atlas to determine which is the fixated side of atlas. What I do is I take my chiropractic index fingers, I hold the patient's head in my hands, and I laterally flex the patient to the right, and my chiro index finger that's on the right TP of atlas as I laterally flex to the right. As I laterally flex the patient, that right TP should kind of dip away from my finger. And as I go to laterally flex the patient's cervical spine to the left TP should kind of dip away from my finger, kind of slide across. If I laterally flex and that TP does not want to translate away from my finger, then that is the side of the fixation. Even though there's less lateral flexion than there is rotation in the cervical spine at atlas, I could really determine which side is fixated that way. And of course, you know the motion palpation you taught is rotational component. It does have the most movement and it can be reliable, but my preference is my lateral flexion fixation. The side of, because that really helps me identify the side of the open capsule. And how much rotation does C1 have to a single side? Between 40 and 50 degrees each side. Just remember, if you add those up, that could add up to 100 total rotation. That often is a question that you may see in the future. I don't know if this slide needs much explanation, but obviously a very traumatic injury to the cervical spine with a huge odontoid fracture and dislocation. And this type of patient will not come into your office. It was just an unusual, crazy slide to show you how extensive a cervical injury can be with that big, heavy head on the cervical spine. It can be sheared off in a high velocity type of accident or injury. Take a minute to look at this film, observe it, and take it in, and let me know if this image is a normal image or abnormal image, meaning a pathological finding for atlas. You could put the presentation on pause while you look at this. Okay, there's a few things going on in this film. The arrows are showing the space between the lateral masses and the odontoid. You could see the amount of space on the right is much larger than the space on the left between the lateral mass and the odontoid. You could also see that the red lines, the vertical lines on the left, are showing that looks like atlas is translated to the right a little bit. So is this a normal or abnormal film? Well, it looks like it may be translated on the left-hand side, but it looks even, maybe slightly to the right on the right-hand side. Okay. Any lateral translation you should consider ruling out pathology first, or is this a film with just a lot of atlas rotation? Because as atlas rotates posterior on the right, you know the lateral mass projects narrower and it opens up the space between the lateral mass and the dens, and conversely, it makes the left lateral mass look larger and closer to the dens. So I would consider this a normal film. It just has a lot of atlas rotation, but you may use your other views to determine whether there's any pathology there. Okay, our occiput subluxation. In our occiput subluxation, similar to like we did at atlas, we have to determine which side has the swollen capsule. And we're comparing occiput to atlas at this time. So we want to know where the open capsule is or which side the wedge is. That also gives us the side of laterality. We determine whether the occiput is an AS or a PS listing. We get that information off of our lateral film. Okay. And the open wedge should correlate with the side of fixation. Suppose you had an atlas. I'm going to go back to atlas here. You had an open wedge on the right on the x-ray for atlas, but you had a fixation on your motion palpation on the left-hand side. Which side would you adjust the patient from? You had an open wedge on the right and a fixation on the left. It's something to think about because intuitively you may say, hey, I need to go over to the left-hand side and free up that lateral mass fixation. Well, if we're moving atlas properly, especially in Gonstead where we go S to I and lateral to medial, is it feasible to take a contact on the right-hand side of atlas, the side of the open capsule, and thrust S to I and right to left? Because if you're thrusting properly, you should move or affect the entire atlas segment and move the left and right lateral masses as compared to C2. Matter of fact, when we do the Gonstead cervical chair atlas adjustment, we're looking for what we call the double clunker. You should hear a double audible when you set that vertebrae. That means you're cavitating both the left and the right side of those lateral masses. And I actually have a neat video. I'll see if I can get it posted on the website of me adjusting an atlas, and you could actually hear the double clunk on the atlas set. Okay. What motion do we use to uncover occiput fixation? You know we use the jaw jut for the PS occiput, and you will learn in lab in the next few weeks that we learn how to do an AS analysis for occiput, because Gonstead does have an adjustment that addresses an AS occiput, and that's done with a reverse jaw jut type motion in which we use a position that we acquire, which is the same as our adjustment. You'll learn that in lab. It's hard to explain without the visuals there. But we do analyze for both a PS and an AS. And for PS, it's the jaw jut, and for AS, it's kind of like a reverse jaw jut. Okay, going back to our cervical spine here and talking about torticollis. Torticollis can be initiated by an injury, some sort of trauma, or it can develop in other ways. But when we have torticollis, we need to determine what type of torticollis we have, and that will help us determine what segments are involved and how to correct it. Okay. We're going to look at torticollis in two categories. One is non-spasmodic and the other is spasmodic. The non-spasmodic is caused by a swollen disc. So if we could recall from earlier, the type of injury that caused the swollen disc is a flexion injury. Okay, and it's typically in the lower cervical spine. That corresponds to a flexion trauma. Okay. For our spasmodic torticollis, it's caused by irritation of cranial nerve 11. The subluxation is usually in the upper cervical spine, typically atlas. And this can be a result of an extension injury, as we discussed earlier. Because when the cervical spine is forced into extension position, the facets can protect the extension of the cervical spine, but then it leaves the upper cervical spine prone to the subluxations. All right, torticollis, cervical dystonia. How could you determine a spasmodic from a non-spasmodic torticollis? There's a procedure we use, and it's very simple. We're going to push ever so slightly on this patient's head. We're going to go into this. We're going to go to the side of the lateral flexion, and we're going to slowly and gently try to bring this patient's head back to the neutral position. When in doing so, Where would the pain be on a spasmodic torticollis? In this case, the pain will be on the same side of lateral flexion. Because of the spasm of the spasmodic torticollis, they're being drawn to the side where they're laterally flexed. So as you go to push the head back to neutral, those spastic muscles will be very uncomfortable and painful. So the patient will feel the pain on the side of the lateral flexion. So that will be the side of our spasmodic torticollis because it's spastic on that side. What side will the pain be for the non-spasmodic? It'll be on the opposite side. Typically this involves a disc injury and we want to move away from the pain, and it's antalgic position for the cervical spine. So as we again try to bring the patient's head back to neutral position, they will feel the pain on the opposite side of the lateral flexion, and that will be considered a disc or a non-spasmodic torticollis. Okay. Our Gonstead chiropractic management of the dystonia or torticollis. Again, we're going to break these down into the two categories that we had earlier. We have spasmodic. All right, we're going to adjust according to our upper cervical findings. It's often atlas is the subluxation here, but when we do our analysis, we are probably going to find an upper cervical subluxation. Okay, if we do not have a current film on the patient, we can take an open mouth film to determine the side of laterality. Remember, if we take our Gonstead film, it also has an open mouth view in it inherently. So if this patient came in with as a new patient for a spasmodic torticollis, if I take my normal Gonstead x-ray, the A to P view has an open mouth built into it because it's an A to P open mouth full spine view. So I could determine my atlas laterality, especially if they're in a lot of pain or discomfort because of maybe this being induced by a trauma or an injury, but also the spasm. That x-ray is going to help me determine which side is the laterality of atlas. These typically resolve very quickly in 1 to 3 adjustments. Again, if they're spasmodic or in pain, I'll probably see this patient every day, so I do expect to get them corrected pretty quickly. This is usually the case. I see pretty quick results with patients if they're not in a full spastic torticollis, but definitely have a specific restriction of the cervical spine and they're antalgic to the left. We usually see those clear up fairly quickly. Okay. And this is really the only time that I will ever instruct a patient to use heat during the recovery at home, and the heat is to go on the spasmed muscles. It's not to go over the cervical spine. It should be on the spastic muscles, and we have to be careful how long we keep the heat there. We definitely have to keep it away from the cervical spine. So heat only on the musculature here. For the non-spasmodic torticollis, we have to locate the D1 disc on the lateral x-ray. This injury to the disc is just like the injury to the disc in the lumbar spine. If the disc is injured, it can become a D1 disc, where the disc presents with end plates that are parallel between the involved segment and the segment below. Also, the disc may be slightly swollen. It may appear slightly larger than the other discs in the cervical spine. So the protocol for correcting this is the same as it is for the lumbar spine. We're going to ice the area of the injury, we're going to pump the disc, and then we will adjust the segment below. This is done on the high-low table. Okay, we put the patient on the high-low table, say it's C6 is the injured disc. We will take a single hand, double thumb, single hand or a double thumb contact on the spinous of C6, and we will pump that disc till we feel increase of motion and the patient being able to tolerate the pumping. And then what we do is we keep the patient prone for this adjustment because they're already in discomfort. What we're not going to do is try to put them in lateral flexion for cervical chair. We can keep the patient prone here, and we can adjust with that single hand or double thumb move now on the segment below. In this case, it would be C7. So we are going to ice it, we're going to pump it, and we're going to adjust the segment below. And we could still do this prone on the high-low table with a single hand or a double thumb move for non-spasmodic. The home instructions for this one are very similar to the ones we use for the acute lower back. The home instructions will include ice on the air for 20 minutes, maybe slightly less if they're a very thin person. We want that ice to get too cold, too deep in that spine, just enough to take care of the inflammation. I am going to adjust this patient or see them 1 to 2 times a day like the acute lower back. I'm going to pump the disc. If they could tolerate that, then I'll move on to the adjustment, and I'll see them twice a day. Okay. The progress of these is typically a little slower than the lower back presentations, so you may expect them to take slightly longer to respond to the care for this, but the protocol is almost identical to our lower back protocol. I have a question here. What is the preferred adjustment for a C2 in the Gonstead technique? Is it single hand underneath chest table, cervical chair adjustment, a prone cervical set on the high-low table, or a supine cervical set? In the Gonstead system, our #1 preferred adjustment for any cervical segment is the cervical chair because of the advantages we can get while having the patient seated. We can get a great amount of P to A. We can lift and open those facets for the C2 through C7. For the Atlas, we can get directly lateral to medial and S to I with our contact, which you'll learn in lab. And we also have the options for our AS or PS occiput listings. But our #1 preferred adjustment for C2 or any other cervical segment is cervical chair in the Gonstead system. The next couple slides here have some questions on them, and these are items that you should know based on this presentation, and these types of questions that typically show up on the exams. So we have this slide as well as our next slide with the questions on what you should know. Have a great day, and I'll see you on our next presentation.